From Henry Ford Health and Henry Ford Jackson Hospital, Vice President of Population Health, Dr. Courtland Keteyian. Welcome back.
Thank you.
Nice to see you.
Yeah, you too.
Here we are, I think, starting year 4 of the pandemic.
Yeah.
But.
Yeah, not anymore though.
Not anymore.
Yeah, not anymore. Yeah, so it was. I remember it was Friday the 13th was the day that that President Trump declared that it was a national a public health emergency. So that was March 13th of 2020, and then the 11th so this week on Thursday is when the public health emergency expires in the United States, which is sort of the administrative signal to end of the imminent danger of the public health threat of the pandemic. And then the World Health Organization agreed, and so this week the World Health Organization, actually last week it was Friday, said that the public health emergency was over. They still said COVID is a public health threat, and the director of the World Health Organization said basically during the statement that somebody dies every 3 minutes globally of COVID. So still, this is a significant cause of a lot of morbidity and a lot of death, but the global emergency is going to end.
And it's not like it's eradicated. It's not like the end of polio. It's going to be with us.
It's going to be with us. Yeah. I mean, the eradication of polio is one of the. Well, it's not really eradicated. We're seeing, unfortunately, that there's cases of polio again in the United States, even, which is hard to believe. But I mean, those were, true, incredible public health successes eradicating polio. But yeah, COVID will be with us, just like the flu on this one. Yeah.
So the ending of the public health emergency, that's great, great news. From a health standpoint, it's a signal that the federal government is going to stop paying for things like vaccinations.
That's right. Yeah. It has a lot of implications. I think for hospitals and for just businesses. Student loan payments are supposed to resume, right? I mean, there's things that's a whole separate issue that's tied up in court. But for people that vaccines were quote free, right? Now those would fall under kind of normal insurance, right? Normal insurance provisions, and there's things that hospitals were getting sort of paid to do that they wouldn't anymore because the emergency has ended. So it's an important, I think, administrative designation, and it changes the nature of now how this condition is managed and things the federal government is reimbursing for.
Are there any people in the hospital right now with COVID?
There always are. Yeah, there always are, and it kind of waxes and wanes. Sometimes we get down to 1 or 2 folks that are in there, but more common is probably 15 or 20, and some of those are people that are in for something different, and then they test positive for COVID, and it could be that COVID is the reason why their heart failure got a little worse or their lung function got a little worse or something like that. But it pretty consistently 10 to 20 people are in the hospital with COVID. They do better than they used to. Fewer of them end up on ventilators in the ICU. We have better tools to treat them. And an outpatient, it's actually really important. This is a really key point for people that people really should make sure they have a good relationship with a primary care doc, because if they get COVID and if they test positive, Paxlovid, the medication, is really excellent. But it has to be, there's a lot of interactions with other drugs. And so you have to have somebody that knows the medications you're taking to be able to navigate around and say, okay, it interacts with this or not with this. And so you have to hold this thing for a couple days. Or we just can't give it to you because you're on a medication that's really important for you. And so you can't be eligible for this. So I think having that primary care doctor relationship is really important. And it's also important to test right away, right? Any symptoms, people this time of year say, well, I have allergies, it's fine, but it could be COVID. And so it's important to test for it. The rapid tests are all over the place and they're cheap and easy to do.
Yeah, and I think a lot of people, we've gotten to the point that, well, if whatever it is, it's something, it's nothing anybody can do anything about. I'll just stay away from people. how important is then for someone with mild symptoms? It could be anything. It could be a flu, could be RSV, could be allergies, could be COVID. How important is it for someone to actually know it is COVID if it is?
Yeah, I think it's essential. I think it's essential because there's no way to really know. There's no way to know what is causing the symptoms unless you get tested. And physicians know this, right? So doctors know that if you come in with symptoms, they're going to have to test you because they have to see which thing it is. And there's treatments, of course, for flu has a treatment, and COVID has a treatment, and those prevent their very worst outcomes. People don't think about flu, but we had there's about 26 million cases of flu in the U.S. this year. About 300,000 people were hospitalized, and I want to say it was about 20,000 deaths of influenza.
For flu?
Yeah, just regular flu. It killed 20,000 Americans this season. So that's still a problem too. So you kind of stack COVID now on top of flu, and there's two respiratory illnesses that are that have a pretty significant impact on people, both short term and then long term as they're trying to recover from those conditions. But yeah, so anyway, it kind of continues to be, even though public health emergency is over, it definitely continues to be a problem for a pretty good slice of the population.
So there are people that you've treated, and there are people that are tuned in that have had COVID, that have had long COVID, that's gone on. Maybe it's months, maybe even it's years.
It can be years. Yeah, it can be years. So that's one of the things that's been really interesting to look at now, I think, as we've sort of settled out and kind of understand that there's going to be waves, right? Like we have with the flu. COVID's going to do the same thing. We'll have kind of peaks and valleys of
Could have a
cases.
touch of COVID.
Yeah. And so with long COVID, that's kind of the generic, sort of popular name. It's also called more clinically post-COVID conditions, or post-acute sequela of SARS-CoV-2. So it's very common, and for people to have long COVID, they have to have symptoms that last at least 8 weeks after the initial diagnosis. And the prevalence of that, the estimates really kind of vary quite a bit, but on the low end, it's somewhere 6 to 10%. On the high end, it could be 40% of people that have COVID end up with some type of long-term, more than 8-week symptom. And those symptoms are grouped usually into 3 categories. There's the respiratory ones that are sort of the classic COVID ones. So cough or feeling short of breath. More sort of body type symptoms like fatigue or muscle aches, muscle pains, or cognitive. They just don't feel like their thoughts are clear. They have problems sort of remembering things. And so when you think about the number of people that are getting COVID, I mean, even if you have like just 10% of those people, we're talking about millions of people in the country that have every year some type of deficit that's lasting for 2, 3, 4 months. And most of them get better eventually, but there's kind of a stabilization. There's people that'll get out to 12 weeks, and it takes a really long time for some of these symptoms to resolve.
It reminds me of Lyme disease in that these kinds of symptoms have some similarity, and then it's forever for some people.
It can really last. And what's interesting too to look at is, so another good reason to have a primary care doctor, but people need to have, some of these things might need to be worked up because it might be that there's a real problem. It isn't just, I'm still tired. There could be something underlying, and they might need their heart checked or their lungs checked. Having COVID, there's been, I think, really good studies in kids now that show risk of like getting type 1 diabetes after COVID is like 2.5 times higher in kids that have had COVID versus not. Heart problems, 2.5 times higher. Clotting disorders, twice as likely. So there are things that could be happening that explain it. So long COVID is kind of a diagnosis of exclusion, like we say. Like you've excluded other things, and so there's something still going on, but it's not something that we can specifically say, right? We sort of worked up and eliminated the other. possibilities. The good news is that there was a really good study that was done. It was published kind of in the middle of last year in JAMA out of Italy. And what they did is they looked at about 2,500 healthcare workers. So people who were really easy to track because they all worked in big hospitals, right? And they had gotten vaccines at regular intervals because it was required as part of their employment at those hospitals at that time. And they actually looked at the prevalence then of long COVID in that group of people. So huge group, right? And what they saw is, in this study, the prevalence or likelihood of getting post-COVID was about, they actually could stratify based on vaccination status. So overall, it was about 30%. So about a third of people were getting symptoms for longer than 8 weeks. In unvaccinated folks, it was 41%. So if you weren't vaccinated, you had a higher risk of getting long COVID. If you'd had all three shots, which at the time of the study, that was what you could get, three vaccines. The risk of long COVID was 16%. So there was actually there was a linear relationship. So the more vaccines you had, there was a linear decrease in the likelihood of getting long COVID. So vaccination significantly decreases that probability, which was that's really encouraging. So that means there's something that people can do to avoid having these sort of long-term problems.
Yeah, so the vaccine, more evidence that it worked. So where are we with the vaccine now? With I don't even know how many vaccinations I've had.
I was trying to remember the other day. I had sort of lost track. So the last one I got was in the fall, and that was when they came out with this new bivalent. So it was treating basically two different strains of COVID with one shot. And that's the most recent iteration or most recent version. The CDC has since said you don't need to get the original vaccine and this new one. All you need is the new one. And that's because these variants continue to evolve, and they're all kind of these newer variants now. So the current recommendation, basically, it differs by age groups and if people have more immunocompromising conditions. But for most people, age like 6 and up, the recommendation is pretty much at this point, no matter what you've had, you just need 1 dose of a bivalent vaccine. So as long as you've had that 1 dose of bivalent vaccine, you're good. And you can see how that's kind of lining up with this sort of once a year cycle, like a flu shot, right? Where once a year we get it. That's the recommendation. You get a flu shot every year. So they've really started to align the recommendation like that. So I think it's going to be interesting to see in the next month or two as we get into the season where we're already thinking about what does the fall vaccine schedule look like, what ACIP and CDC say about that. But probably it'll be the single dose, and there'll be debate, I think, about whether there's a new vaccine or not. If we need something different to cover circulating strains, or if the existing one is sufficient.
And it's going to be an annual thing from here on out.
That's my guess. Yeah, that's my guess.
All right. And you don't have to wear a mask in the hospital anymore.
No, which has been really nice, actually. I was in clinic this morning, and I kind of had forgotten. I've had patients that I've seen for years, and I had forgotten what some of them look like. So it was sort of nice to see people and see their faces. So I've been enjoying that.
All right. Well, that's good. We're headed in the right direction.
I think so. Yeah.
Thanks. Well, thanks for all the great info. And good to see you.
Yeah. You too. Thanks.
Dr. Courtland Keteyian, Vice President of Population Health at Henry Ford Health, Henry Ford Jackson Hospital.